And welcome back to the Pretty Healthy Podcast. I am your host, Dr. Brandi Moore, and today I have a very special guest, Dr. Andrea. Dr. Andrea is a physical therapist who has been in practice since 2017. She has an extensive background in both orthopedic and pelvic floor therapy, and her mission is simple. She wants to make pelvic floor therapy a standard of care, and she thinks every person deserves to have direct access to pelvic floor therapy. So let's get into it. Welcome, Dr. Andrea.
Thank you for having me. I'm so excited to be here.
Yeah, I'm excited to have you and to have this conversation because I feel like it's one that is so needed and that is not often had by providers. I really want to know how you got into pelvic floor therapy because it's not a common, I would say, specialty in physical therapy.
Yeah, absolutely. It's a great question because if you would have told me I'd be doing this, when I was in PT school, I think you're crazy. Because we didn't talk about this in our doctorate program. So I remember having one class, 1 hour to 2 hours on pelvic floor physical therapy. I was like, I'm not interested at all. I think it's geared only to pregnant ladies. I am not passionate about it. So it wasn't until I was working in outpatient PT at the time, and so orthopedics, and we had a pelvic floor specialist on staff. And my boss at the time was, asked if, are you interested? Like, I don't think so. I love orthopedics. I love sports medicine, but let me take a class. So I took the class, fell in love with the course that weekend after finding out that I had pelvic floor dysfunction at the age of 25 years old. I've never had kids. I've never really had, the common symptoms of pelvic floor dysfunction, but yet I was so uncoordinated and had no idea. So it was mind-blowing and made complete sense with a lot of my chronic back pain patients, chronic hip pain patients. I'm like, wow, light bulb just went off. It's the freaking pelvic floor. And so it changed my whole treatment style. It changed more of a holistic approach, looking literally head to toe, including the pelvic floor, including what I thought was the core, but it really wasn't. So that's how I got into pelvic floor PT. So now that's what I treat.
Yeah, which makes complete sense. Like, I'm not really quite sure where in medicine we veered and said like, oh, you're an arm, you're a leg, you're a back. And like, right. I only look here in this like really tunnel vision and I don't look at anything else. And if anything else is wrong, I'm referring you to someone else. It really breaks up that continuity of care because then the physicians themselves don't have a conversation and say, oh, well, they told me this, oh, they told me that, and then compare stuff. So that's really awesome that you do take that holistic approach. Can you give some signs of pelvic floor dysfunction that people might not know that they have?
Yeah. So mine, I'll speak from a personal standpoint. I had low back, dull pain during my periods, and that was a prolapse, and I had no idea. Or pelvic floor dysfunction. So not to get too technical, but low back pain can absolutely and most likely mean you have pelvic floor dysfunction, SI joint. So any sort of sacroiliac joint dysfunction, you probably have some sort of pelvic floor issue. The common symptoms, any sort of urinary leakage. So with its, sneeze, laugh, cough, exercise, trying to get to the bathroom, even if it's temporary. So think about, bedwetting, even with kids, that's pelvic floor dysfunction. Any sort of heaviness, pressure, pain down there, any sort of numbness, tingling, lack of sensation, and then go into sexual dysfunction. So whether you have pain with sex, whether it's not pleasurable, whether you can't orgasm, all of that is pelvic floor related.
All of that too is very easily masked into something else, right? Like you're saying like, oh, it's just your back. You sprained it and that's what's wrong. Or kids bedwetting is a good one. I actually didn't know that was a sign of pelvic floor dysfunction because it's always said that it's like nightmares or night terrors, or they're just in a phase, like they're just bedwetting and that's what happens. But do you treat kids?
I do not. So there's pediatrics pelvic floor PTs. I do know enough to guide the parents because I have a lot of parents that I work with and they ask questions about, the kid being backed up, constipated and bedwetting. So I give them general advice. It's tricky with kids because you don't do an internal assessment. You got to really establish good communication. But long story short, no, not directly, but sort of indirectly helping my clients that are parents.
Okay. That makes sense.
Yeah.
It would be really tricky with that. So speaking of an internal exam, I feel like even I've personally been referred to a pelvic floor therapist post my second baby, not my first. And it was really at my own alarm of being like, what is happening? I don't know. And my midwife just being like, oh, well, here I have a pelvic floor PT that I really like. Go see her. And I wasn't aware of what the exam was going to look like. I wasn't even sure why I was going. I was, as a doctor, sometimes you know too much.
Absolutely.
So I was like, my uterus is prolapsing. I was like a few weeks postpartum, like it wasn't prolapsing. Everything is just different. And I feel like we don't talk about that phase. It's like you have the baby and then it's like, see me in 6 weeks and like, oh, things look good. See you in whenever you need your next PAP, like a year from now. So what does that assessment look like? If someone's referred to you, what happens next?
Sure. So again, I'm completely cash based now. So it's a lot different than what I've worked at in insurance and what I know insurance providers assess. So my biggest thing is if someone is listening, when you do listen, I urge you to go see a provider that is one-on-one and is typically out of the network because they will give you a full hour and a half assessment. So what that looks like, we look head to toe. So, I've had your subjective complaints. I know what you're coming in for because I've had a discovery call with you. So I know everything. When we, meet in person, we just briefly go over that again. We start with a postural exam. So looking everything from your TMJ, because that's going to connect into your pelvic floor. Clicking, grinding, any sort of clenching up in the the TMJ is going to connect. We got to look at the shoulders. We have to look at the belly button, the ribs, the pelvis height, the knees, and your feet. So I'm a big foot person because that's going to distribute weight up to the pelvic floor. So that's postural. I get a ton of information just off of that and standing. From that, we go into movement analysis. That's going to look different for everyone. So let's say I have a athlete coming in and they can't do double unders without leaking. I'm going to have that athlete show me double unders. So I can see if it's form related, what are they doing with their breath? So we can put it all together when we do get into the other parts of the exam. If it's just, someone that's just doing yoga per se, or just walking and just wants to get aerobic activity in, then we're going to do a gait analysis. I'm going to look at single leg stance because everything requires some form of single leg repetitive activity, and then hip hinge. So like squat. A lot of people do squats inappropriately or not with the right cues that we'd want for our pelvic floor to be on board with that. After the postural exam, after the movement analysis, that's when I break out into the orthopedic assessment. So this can go different ways, again, depending on what the person's really coming in for. But in general, I'm looking at your spinal mobility, your pelvic mobility. Hip mobility is huge, especially for a pregnant mom. We want to look at hip internal versus external rotation, since that's going to, bias potentially early labor versus mid labor versus pushing stages. Looking at strength, coordination of the glutes, muscles in the front of the hip, the side of the hip, the inner thigh. Then we break into an abdominal assessment. So if anyone comes in with constipation, with IBS, post hysterectomy, post C-section, I want to feel how that tissue is moving or lack of movement. Core imbalances, checking for diastasis recti, hernias, all of that. And then lastly is the pelvic floor assessment. So that's only with consent. It is not necessary, but typically most people consent to it. It's an internal exam, typically vaginally. Start lying down. It's with one gloved finger. And so just like I would touch your quad or your upper trap muscle, I'm doing the same thing to the pelvic floor, checking for tone, checking to see, can it contract, but can it relax? That's even more important there. And then just overall coordination, we look for prolapse, pelvic organ prolapse, the big diagnosis that we treat. And then at the end, we put it all together and go into treatment. So it's a lot.
Yeah.
It's a lot. I'm like gasped from talking, but it is a lot.
I love how thorough it is.
Yeah.
Because it makes complete sense when you talk about, just how your posture up here affects every single muscle, because obviously if something's off, your body will compensate. And so it makes sense that it will affect your pelvis, even though you're thinking like, why are you checking my jaw? It makes sense. Just if you're holding tension here, are you holding it anywhere else? Do you have any other dysfunction that's causing that pelvis to be off?
100%.
So it starts with a discovery call first.
Yeah. So I always talk for 20, 30 minutes. So right before this podcast, I had several of those. So again, I want to make sure we're a good fit for one another. If we're not, then, you know, I'm so happy to refer out to whether that's a functional med or chiropractic care, whatever it is. I want to make sure we're a good fit for each other before, you know, you do dive into that 90-minute assessment and take that route with pelvic floor therapy.
That makes sense. So I'm a cash pay provider as well. And a lot of times people do want to use their insurance, but I like the fact that I don't have someone telling me what I can and cannot do. What I, as the trained physician, I don't have a business telling me with the doctorate that it's worth me doing this lab or that lab, or this amount of time I should only be able to spend 20 minutes with a patient coming in, or that I'm only allowed to give this medication as an option and I can't give anything else. It's so nice as a provider to say, I'm going to provide the care that I think is necessary based on my knowledge and experience. And it's regardless of how insurance values your health is really what it comes down to.
Absolutely.
And that sick care versus true like healthcare, that holistic perspective.
Wellness versus preventative. Yep.
Yeah. Because there's so much that you can prevent. I mean, why not refer to a pelvic floor therapist to treat a minor prolapse versus waiting until your uterus is in your vagina and then being like, oh, I approve surgery.
Right. Absolutely. We get that all the time. It's so freaking frustrating. I'm like, if what they need, because with the surgery, you're not typically getting to the root cause of it. And so I see those patients post-op in worse care than they were going into the pre-op. And they need pelvic floor PT. I'm like, if you would have only seen a pelvic floor therapist prior, you probably would not have even needed that surgery.
Which would be so frustrating. Because
so frustrating.
That's frustrating on all sides. Because even, again, with my first baby, and I feel like with most OBs and midwives tend to be a little, obviously, more holistic thinking, but it's not standard of care to say like, okay, you see me, and then at 6 weeks, go see a pelvic floor therapist just for an assessment. Like the worst thing that can happen is they're like, everything's great, your body's healing, but here are some exercises to help tone this and to help prevent diastasis recti. Like, here you go.
Absolutely.
But it should just be part of that 6-week follow-up.
Yeah. And it's not. It's oftentimes, oh, I've waited for 5 years, or finally, you know, I've seen you on Instagram. I followed you on Instagram for 2 years. I'm ready. Instead of automatically referring that mom out, instead of just saying, oh, you're good, let's return to sex, let's return to exercise, whatever you want to the 6 weeks. Let's disregard, you know, you still have stitches or you still have pain down there, or you feel like something's coming out, but that'll just eventually retract, you know, and that's not the case. So it's extremely frustrating. I hope, you know, this will change. I see minor changes, but we still have a lot of work to do.
Yeah. So we've talked about kind of the assessment, how you got there, but if you could kind of break down exactly what pelvic floor therapy is, just in case anyone hasn't kind of followed our conversation to this point.
Yeah. So I think it's important to break down what the pelvic floor is, because most people don't even know where that is on their body. So if you think about attachment points, so your pubic bone in the front, slinging all the way back to your tailbone, in between your two sit bones. It's like a hammock-like, sling-like effect. That's your pelvic floor muscles. So essentially what you're sitting on. Okay, so they're a sling of muscles. They're going to support our pelvic organs. They're going to maintain continence, and then they're going to help with sexual function. So that's pelvic floor in general. So if we can't have those functions go correctly, that's when we have dysfunction within the pelvic floor.
Okay. That makes sense. So the muscles that you're sitting on, they're also the muscles that you use to pee and poop and push. Like pushing, it goes down, right?
Correct. Yep. So we'll have it for peeing, pooping, gas as well. Absolutely. And then sexual function. So the 3 holes in women, and then, you know, obviously the urethra, and then the anus in the man. So all very similar structures, man versus women, just different external genitalia.
Yep. That makes sense. Now I think it's a good time. We're going to get into some myths and facts about pelvic floor therapy, because if you have followed Dr. Andrea at all on Instagram, you would know that she points these out all the time.
Yeah.
All of her reels, which I love, are all very focused on a lot of misinformation within that industry, within the pelvic floor industry. And I would say not even among the therapists, it's among the other providers that would refer, it seems like, or like insurance companies or things like Cosmopolitan magazine, which I don't even know if it's still popular, but I feel like when I was coming up, it was very like, oh, get the latest Cosmo and it tells you to do Kegels to get like a tight vagina. But like,
100%. Our society is so focused on that. There's still dumb articles out there that, I even have a Thirst Trap Thursday that we do on our private Facebook group. And we're debunking these articles that people read into, or, let's say Kourtney Kardashian posts something on Poosh, her website.
Yeah.
We want to debunk stuff out there that people, hold to like such a high standard. Like, guys, it's not true.
It is very hard to combat mainstream media misinformation. Yeah. That's what 100%. I'm just going to call it from right now. It's so frustrating because you see something, even in like my industry, I do a lot of herbs, acupuncture, holistic, like I'm a naturopath. So it's a lot of integrative medicine. And there's a lot of just, you are this or you are that, and you believe this. And I'm like, first off, there's not one group of anything that all agree on one thing.
Correct.
Let alone we all practice the same and have the same ideas. But okay, so we're going to call this the last interview I did a segment called Do It or Screw It, where we went over skin trends and it was like, should we do it? Nice. Should we not? So we're just going to call this pelvic floor myth busting. Okay. We're the myth busters today. So the first one I want to talk about is the myth being that there are only certain exercises that you should be doing if you have diastasis recti, which is abdominal separation for anyone who doesn't know.
Correct. So if you do a quick Google search on diastasis recti, the first thing that's usually going to pop up is don't do X, Y, and Z. So the usual don'ts are a sit-up, a plank, any rotational movement, a push-up, which is complete bogus because I work with diastasis recti on the regular. And it's just an easy sell. It's an easy read for consumers to buy into, but it's not individual whatsoever. I have ladies throughout pregnancy that were trying to sort of not prevent diastasis, because diastasis is going to occur if you carry to full term, but manage those symptoms where it's healing in the postpartum period. So the biggest things with these movements is the quality. How well can you do these movements? Are we having any dysfunction? Are we having the coning is what you'll see if you do have diastasis recti, the bulging, the sort of mom pooch. What does that look like? What does that feel like? Are you having pressure in the pelvic floor? So it's all about quality, how you can perform that and why. What's the intention? Why are we doing sit-ups? Why are we doing a plank? Do you even know why you're doing a plank? Do you know why you're doing a sit-up? It's super important for someone to be able to do a sit-up. We sit up every single day and people don't realize it. But what these quick lists of don't do X, Y, and Z just creates fear of movement. And so when I see these moms, even men, when they come to me like, oh my gosh, you just made me do a sit-up. I thought I wasn't ever supposed to do a sit-up again. So it's sad. And if I could only preach that, just don't subscribe to those people that have, safe versus unsafe or do's versus don't do's with diastasis recti. Our body's way more complex than that.
And that makes sense. So a lot of these are also recommended during pregnancy to not do. Correct. And I'm like, how do I not sit up during pregnancy?
Exactly.
Especially my second baby, it's like, am I just not supposed to pick up the first one? Like you're saying, what I wish I would have known is the proper way to pick up that second baby so I didn't make it worse. So question, you can make it worse by doing said things incorrectly.
Absolutely. Okay. Yeah. Because all of those exercises put a lot of pressure through our spine, through our pelvic floor, through our abdominal wall. So the linea alba that does separate with diastasis recti. So yeah, if you continuously do those exercises inappropriately, but that's going to do, you could do that you can say that with anything. You could do the same thing with squats, but those aren't usually on the don't list. So again, it's all about intention and then the quality of the movement.
Awesome. And then the other thing about diastasis recti is that men can have it too.
Absolutely.
Correct?
Yeah.
So why is so much focus put on women? And I found this out because I went to pelvic floor therapy, like I mentioned, and we did a lot of like focusing on making sure the abs were engaged prior to doing certain exercise, like making sure I've mentally can see that the coning is not happening when I'm engaged versus when I wasn't engaged, the coning was there. And my husband went to do a sit up or a crunch. And I was like, you have coning. And he's never had a baby, obviously, because men can't have babies, to debunk that myth real quick. But it was why is that so missed and so much emphasis is put on women only fixing that?
I don't know where this goes back to, but for some reason, it's only typically in the literature with DR, diastasis recti, throughout pregnancy and postpartum. But I'm telling you, I've seen probably 85% of the men that I treat have DR, diastasis recti. Mm-hmm. And of course, I've never had kids. They're usually athletes. So they're still young. They're not overweight. I do have some that are overweight, but a lot of them are athletes and they're in good shape. But diastasis recti all comes down to pressure mismanagement and imbalance, muscle activation and coordination. So a lot of athletes develop that, especially men, because I focus on upper abdominal activity. So think crunch, sit up, instead of activating from the bottom of the pelvic floor. And then oftentimes too, because people think men don't have pelvic floor. So I think it's a lot of contributing factors into it, which is really sad because, I evaluate a lot of men and, I'm the first one that have shown or have, seen the DR in them. And they're like, oh my gosh, I've never seen this before. Or they have, and the doctor's like, oh, don't worry about it. It's just probably a hernia. It's not going to do anything. I'm like, you probably should start addressing that,
So if you don't address diastasis recti, what can that look like down the line?
Down the line, so after DR, it can develop into a hernia. Okay. So that's when people will have, any sort of hernia, umbilical hernia. It could develop into inguinal hernia, even though it's not the same connective tissue. But again, it's going to also hemorrhoids, prolapse, all of that, because they're all pressure mismanagement issues.
So the hernia just being that you get an outpouching of the intestines through that abdominal separation, correct?
Correct. Yep. Okay.
Very cool. Lots of stuff there with that. Okay. Next big one, which was kind of mentioned, but Kegels are the miracle exercise to fix the pelvic floor. True or false?
False.
False. Okay.
Absolutely false.
Why do you know how, and you might not know how that got started, like how Kegels became the one thing that everyone talks about? Someone
can 100% fact check me, but there was a guy, his last name was Kegel, however you want to patata pronounce it. He came up with Kegels and the pelvic floor contractions. And I think our society was so big on having a tight vagina. And so that's what people started harping on, if you want a tight vagina, if you want to have, sex feel so great, or, to have your partner to be pleased in the sexual world, we got to do Kegels. We have to do pelvic floor contractions. So I think that's where it all stemmed from. And then just lack of knowledge in the pelvic floor arena. Like, hey, that's only one part of the contraction of the muscle.
Well, and that's, I feel like the other side of that is everyone talks about if your vagina is not tight enough, right? Especially post baby, but no one talks about if it's too tight,
right?
Like you can have too much tone in the vaginal canal, correct?
100%.
And Kegels would make that worse.
Yes.
So how might someone know that they have an overtoned vaginal wall?
So some symptoms of overtone or hypertonicity is what we call it, non-relaxing pelvic floor. You're going to be having symptoms of potential constipation. You're going to have urinary frequency, urinary urgency. You might have pelvic pain, so just sitting hurts, pain with sex, or any sort of sexual dysfunction as far as not being able to be pleasured with intercourse. So those are top signs of hypertonic pelvic floor.
Okay. So if you have, or you're curious if you have signs of a hypertonic floor, then obviously see a pelvic floor therapist. When I went through the process, I found that the assessment from this industry is very in-depth. like not only the like full body exam, the vaginal exam, but also I had like electrodes put on my pelvic floor muscles. And then I could visually see like if I was using my muscles or not using my muscles, or if it was too much tone or not enough tone. It's very fascinating. Is that something you use with your clients as well?
So what you're talking about is biofeedback.
Yes.
So I don't use electrodes. I'm a big tactile cue. So I want to use my hands to get feedback, but it can be a great tool as long as we progress past that.
Gotcha.
At some point. Yeah.
So how do you properly do a Kegel?
Yeah. So again, if you think about the pelvic floor muscles, they're going to wrap around the urethra. They're going to be at the opening of the vagina and then at the anus. So imagine you're in an elevator right now and you're standing next to your crush and you don't want to let a fart out. So what would you have to do so you don't pass gas? Yeah. You're going to contract around your anus and that's going to zip up, hopefully, to the urethra. So any sort of cue. So that's the Kegel. It's a pelvic floor contraction. You're not using your glutes. You're not using your buttock muscles, your inner thigh muscles. So all those people crossing their legs with a sneeze, you're not. That's why you're still leaking. You're not using your pelvic floor. Not holding your breath. So no compensations. So what I like to use is the elevator example there. Or just imagine you have a blueberry at your anus or a blueberry at your vagina and you're bringing that blueberry up inside of you as you breathe out. So that's the cue to start getting your diaphragm and your pelvic floor on board.
So why not the typical stopping the stream of urine?
So the stopping the stream of urine can be bad because people will practice Kegels on the toilet. And what that does is teaches our pelvic floor muscles to not relax when we're urinating. And that's the complete opposite of what we should be doing. So when you urinate, you should completely relax the pelvic floor. They should completely lengthen. So like we mentioned earlier, a lot of people have hypertonicity. They have too much tone. So if we are engaging those pelvic floor muscles while we're urinating to see how strong our pelvic floor muscles are, that's going to send negative feedback to our bladder. With that being said, that negative feedback can turn into chronic UTIs. So chronic buildup of urine into the urethra. So we see a lot of women with chronic UTIs and then that urinary urge, that pain, pelvic pain in general. So don't ever do Kegels while urinating. And if you do, maybe make it once in every 3 months. Make it very infrequent.
Okay. So you don't want to be practicing on the potty is what you're saying. No practicing on the potty. Okay. Next myth, that peeing your pants is just part of life postpartum and that every woman deals with it and should just get over it.
That is completely false. Unfortunately, as mothers in the society, you're kind of told that's just the way it is. You've had a kid. What do you expect? Your pelvic floor is ruined. RIP to your pelvic floor. But that's not the case. The pelvic floor muscles, just like any other muscles, can be trained. They can be rehabbed with an appropriate provider to help you, aka pelvic floor therapist. So don't just, deal with it in the postpartum period or, older ladies, same thing. People just say, oh, you're older, you're postmenopause or, you have hormone imbalance and all this kind of stuff. Again, muscles, our body is fascinating. It can learn. It is never too late to rehab if you are having urinary incontinence. Again, whether that's every so often and not every time you sneeze, that's still it's not normal. So get that checked out. It's an easy fix typically.
And it doesn't matter. I want to reiterate this. It doesn't matter how long it's been an issue.
Correct.
So you're 75, well beyond postmenopause and had 2 kids or 3 kids or whatever, you can still benefit from pelvic floor therapy.
100%. I've had people 75, 80 years old, post-stroke, they've had kids. So not only have they had kids, they've been through menopause, but they also have now had this neurological disorder and they've gotten better. So I promise that it can be achieved.
That nothing's too far gone.
Exactly.
Something else that I saw on your Instagram was talking about like you wouldn't go into a marathon never having trained, right? So like, why are we going into birth that way? Is there kind of general, I guess, ideas about what you should be doing pre-birth? Because as someone who has had 2 kids, I have never heard that you should be doing anything before except, living your life and trying not to stress, trying to stay active. But I've never heard of anything specific to the pelvic floor that I should have been doing prior.
Okay. Are you ready for this? This is a big soapbox of mine. So yeah, like I mentioned, again, you don't go into a marathon without training, or you shouldn't, or you're going to get injured most likely. So same thing with childbirth. Childbirth is a marathon. It's endurance. You're usually not popping the baby out in 10 minutes. And there's so many biomechanics that go into early stages of labor, mid-labor, pushing stages that we can work on as pelvic floor therapists to help that baby come through the inlet. So achieving that cervical dilation, achieving that cervical effacement, and then making its way through the mid pelvis. So the mid pelvis, a lot of people stall in labor because of their tone in the pelvic floor. So back to the whole tight vagina, a lot of people stall simply because they have hypertonic pelvic floor muscles. So it's super, super sad and frustrating when I do see those ladies that, they did have to have a C-section, or they did have to have an episiotomy, and it was simply their pelvic floor muscles not giving, not having that good elongation. So that's a huge focus on our pregnancy or throughout pregnancy, ladies that we work with. How well can you lengthen those pelvic floor muscles safely? How well can your perineum move to the area in between the vagina and the anus? Because let's face it, that has to move around 3 to 3.5 times its resting length. So if you're already rested in like a 40% contracted state, you're going to work a hell of a lot harder than someone that has good length in the pelvic floor. And that's when a lot of people, again, poop out during the labor and delivery process, and they're just freaking fatigued. There's different positions that are more beneficial to get into, hip external rotation, feet out. So think of like a sumo squat or like a wide squat that's going to benefit, the baby coming down through the inlet, versus like a lunge position or 1 foot higher than the other. That's going to benefit mid pelvis. And then at the very end, the pushing stage, it's going to be more beneficial for knees coming in. So hip internal rotated position. It's just no one knows this kind of stuff. And it's super frustrating, and it's so easy to prehab is what we call it. And those people benefit so much better in the postpartum and have very little issues postpartum.
It makes so much sense though, just from a physiological perspective, that if you're able to get to a certain point and then you're stalling out, it makes sense that it's just too toned, or it's hypertonicic. Why words hard? It's very toned in that area, making it harder for the baby to descend into the birth canal. But
100%.
Society is just like kegel, kegel, kegel.
Yep. I feel like immediately when you get pregnant, they're like, "Oh, girl, you better start doing your kegels." I'm like, no.
That is what they say, though. That's so true. Yeah. Okay, so what phase should someone prehab in their pregnancy? Like, should you see them in the beginning, that last trimester? Like, when is a good time to come see you?
Yeah, typically the best time that people start responding is second trimester. So first trimester, it's a little whirlwind, whether you're sick, you're fatigued, we don't do internal exams if someone comes in the first trimester, but second trimester, we're ready to rock and roll. So even outside of preparing for labor and delivery, we work on, around ligament issues. So if you have that lightning crotch symptom, pubic symphysis dysfunction, SI joint issues, low back issues, swelling in the lower legs, all of these things that we're just accepted as being normal throughout pregnancy, it has a reason that it's happening. Acid reflux, heartburn, all of that we can address with pelvic floor PT.
That, for anyone who's pregnant and listening, must be music to your ears, because you are just told, like, it's common, therefore it's normal, therefore you just have to bear it for the next X amount of months. But like acid reflux, it makes sense why you're having it. You have a baby growing, your stomach is getting compressed, like that makes sense. But to know that something as simple as addressing where you're holding pressure, how you're holding your body, how you're holding your pelvic floor can make a difference is
mind-blowing, right?
Yeah, makes all the difference.
A lot of it too, again, because we don't get taught this in PT school. So a lot of it has been from continuing education, but also just learning on my body and learning on, other clients that I work on. So even with like the whole heartburn and acid reflux, we used to have like really bad hiccups. And so like when I would hiccup, it would just be so loud and obnoxious. And last forever. None of like the wives' tales I've ever worked. And so I just simply started working on my diaphragm, releasing my diaphragm, releasing the lower esophageal sphincter that we get into with, ladies that are pregnant. And it worked wonders. And so I'm like, wait, I need to do this on my pregnant ladies. And it works. They don't have heartburn. They don't have indigestion. They don't have acid reflux. So she's like, gosh, this makes so much sense if someone would just give this person the time that they deserve and to look at everything.
Yeah. And from a naturopathic perspective, just popping someone on Nexium does nothing but make it worse. It decreases your ability to absorb things like B12. Like it causes so many issues down the line that to have a solution like this when someone's pregnant just makes way more sense than being like, here, take this pill. You're just pregnant, get over it. Or even just that round ligament pain. I saw a chiropractor and it helped. But my OB or midwife, no one said there's something that you can do here. Go see a pelvic floor physical therapist. But again, you've got tight ligaments. Like it makes
they're so super stretched out. And so we look at it obviously from the internal standpoint. So round ligaments can attach into the labia. So, oftentimes it's really good to work with the Webster certified chiropractor and then pelvic floor PT in conjunction, because they do a lot of obviously the external, the bony structures, whereas we can find the actual attachment point. Like, and so many people are like, wow, I can't believe how tender this is. That makes so much sense of the symptoms they're having.
Yeah, that makes a lot of sense. Okay. Painful sex. That sex, like painful intercourse is normal. And again, we should just kind of deal with it.
False.
No. Okay. What are some of the reasons why someone might notice that?
Yeah.
Might be the cause.
So there's a ton of causes potentially for that, but even outside of pelvic floor PT, so hormonal imbalances, so changes in vulvar structures, if you're on birth control, there's a lot of research with prolonged birth control and changes in the vulvar tissue. So the tissue outside of the vagina that can contribute to the dryness, contribute to the thinning of the vulvar tissue. So all of that can contribute to, painful intercourse. But also, the biggest thing is the hypertonicity in the pelvic floor. So with intercourse, using a tampon, any sort of insertion, our pelvic floor muscles should be completely relaxed and be able to open essentially. And with any sort of guarding or unknowingly having tension there in the pelvic floor, having that repetitive pain upon insertion, you're just going to keep on guarding every single time. And then it becomes like this vicious cycle. So, the person, then is battling mentally, they're preparing that it's going to hurt. And so that guards you even more. So it's a complete cycle of the hypertonicity in the pelvic floor. What kind of foods are you introducing into your diet? What foods are you not introducing? So is it an inflammatory process? Is it lack of water intake that's impacting the bladder, that's impacting the bowels? So a lot of things we have to look at. That's why working with someone like yourself is crucial with someone with pain with sex. Again, all kind of, making sure the OBGYN is on board as well. So what are they prescribing, whether it's birth control, the IUD, estrogen cream, whatever it is, all that's going to feed into the pelvic floor.
Yeah, that makes sense. And also, I feel like there's not enough conversation about the neighbors of the vagina, which you mentioned, your bladder and your intestines, that if there's issues in either one of those areas, you'll see that reflected in what's happening with the vagina.
Yep. And then one thing I didn't mention too, a lot of women, have stitches in their perineum postpartum. So that is a big contributing factor to pain with sex postpartum. Because if no one, releases that scar tissue where you're going to have scar tissue from stitching, that's going to make it very painful with any sort of insertion. And then C-sections too, just from the nature of the major abdominal surgery. We see a lot of pain with sex post C-sections.
Wow. Because you wouldn't think that would affect that, the stitches make sense, but you wouldn't think that the C-section scar would affect that, but that makes sense too.
Mm-hmm.
The last one I want to talk about, because it is so common, is constipation and its effect on the pelvic floor, because a lot of people run around constipated. I treat a lot of thyroid disease that comes with constipation. I'm telling people things from, eat a vegetable a day to drink more water to treat it. But they often think I'm just constipated, no big deal. But from your perspective, it can have effects down the line. So what do you see there?
Yeah. So when someone does have chronic constipation, a lot of times it does stem even back to their childhood. So they're the ones that had bedwetting, or, they didn't want to go have a bowel movement as a kid. So I have to think, when I see them in their 20s, 30s, 40s, like, wow, this has been going on for a long time. Why? Where is it stemming from? So that's all we do, or I do the abdominal assessment. So are they limited around the ileocecal valve? So are there restrictions around that? Are there restrictions, again, going from the esophagus to the stomach? Where are there restrictions along the intestinal wall? So we examine a muscle called the psoas. It's a hip flexor. On the right side, that's going to run over the ileocecal valve. The left side is going to run over the rectum. So it could be as simple as having a tight hip flexor, for God's sake, for constipation. And that's the stuff that we look at. And then from the pelvic floor standpoint, again, for bowels to come out, for urine to come out, our pelvic floor has to be completely relaxed. So again, if you have that hypertonicity in the pelvic floor, so it's too tense, that's going to back up feces. Okay. So chronic, backing up, blockage, that's going to affect a lot of stuff, even mental issues. So also with, we've talked a lot about the hypertonicity, but the coordination of the pelvic floor is huge. So oftentimes when people sort of do have that urge to go, their pelvic floor muscles automatically contract instead of wanting to sort of bulge and let go in the pelvic floor region. So that's everything we have to look at. We have to look at positioning. So squatty potty is legit. It's biomechanically makes sense of why we want to get into that position. So little things like that. And like you mentioned, the fluid intake, we have to look at that. That's huge. We have to look at food. So that's when, again, that's out of my scope of practice. I always refer out for that, but that has to be discussed because it's a whole holistic approach that has to be done for constipation.
It's good to know that the squatty potty is legit because, and it does make sense, but it became really popular. And I feel like we mentioned this, but some trends in that realm, you're like, but should I be doing it or should I not? But the squatty potty is legit. Is that because it just helps with the angle that your hips are at? Okay.
Exactly. Yeah. So ideally you want your knees above your hips. You want to make sure you're completely relaxed. So what that does is put the puborectalis in a better position. So that's the muscle around the anus. So we don't want that too tight or you're going to get, stuck. The bowel's going to get stuck. So with your knees above the hips, that puts that puborectalis at a better position to now let the bowel movement or the feces come through.
Okay. That makes sense. How can someone find a good pelvic floor therapist?
So there are some directories out there. Pelvic Guru does have a directory online. However, a lot of good pelvic floor therapists, I'm not on there because it does cost money to even just be on the directory. But simply a Google search. And what I urge people to look for, because I have a ton of people out of the country, all over the United States reach out, like, I need to find someone like you in my location. What do I need to do? So what I look for is they're going to be one-on-one for you for at least 60 minutes. Typically, the best providers are working out of network, unfortunately, because insurance isn't dictating how long that we can work with you. Insurance isn't dictating what I can treat for you. So for the best providers, you're going to want to look for one-on-one. They're working for at least 60 to 90 minutes with you. They're typically going to be out of network and they're looking holistically, meaning they look outside of the pelvic floor. They look head to toe. Okay. And so when you Google search, you'll know by looking at someone's website.
Okay. That's helpful. So knowing that physical therapists by and large are not taught it as part of their program, pelvic floor therapy, is there any additional certifications or anything to look for in that regard? Or okay. So just doctor of physical therapy, and then obviously it would just be their specialty. Yeah.
Pelvic floor. You want to look for pelvic floor PT. So if you did Google it, and then also interview your pelvic floor PT, call them, talk with them before you schedule an appointment with them. There's a lot of times where if it is with insurance or an in-network provider, they're not going to talk to you. They don't have time to talk to you. So talk with them, see if they can address your freaking plantar fasciitis when, you're coming in with pelvic floor issues. If you're going to a good pelvic floor therapist, they should and will address that kind of stuff.
Okay, awesome. And then how can someone work with you?
Yeah, so I'm in Tampa Bay, Florida, so covering Tampa, St. Pete, Clearwater, so all of that region. But also I do a lot of virtual. So I'm from South Carolina. The care in South Carolina is horrible for women's health just because I'm from a rural area. So a lot of the people where I'm from, they have to travel 2 to 3 hours, and that's not doable for them to go see a pelvic floor therapist. So I work virtual. Those assessments are still 60 to 90 minutes, and we get great results with that. So get in touch with me. My Instagram handle is an easy way and a fast way to get in touch with me. My email address as well. So those are the top 2 ways to get in touch with me.
Awesome. So I will put all of Dr. Andrea's information down below so you guys can find her and work with her. That's awesome that you are able to do what you do virtually, because it does make it more accessible to people. And that is something that within my industry is also a thing. We're limited in what states where we are. And in your state, there might only be one and they're 3 hours away. So having someone who's able to do a virtual consult is beneficial in that way as well. Well, thank you so much for taking the time to talk to me today. It's been a pleasure learning more about what you do. Everyone, please follow Dr. Andrea on her Instagram. Again, I'll put all of her social website contact information down below. And thank you so much for tuning into this episode. Please, if you're listening on Apple Podcast or Spotify, give it a rate and a review. It really does help this podcast be seen by more people. And then if you're watching the video on YouTube, please subscribe, like, comment, engage with me. I really do like engaging with you guys. It's one of my favorite things. So thank you again for tuning in, and I will see you next week.